Welcome to the Deep Dive, where we crack open dense topics and extract the most important nuggets of knowledge for you. Today, we're diving into something you might not think about often, but it's incredibly vital in medicine: the intricate world of surgical coding for the integumentary system. You might think skin. How complicated can that be? But it's actually a fascinating look at how medical procedures get categorized and documented with incredible precision.
Absolutely. Our deep dive today pulls directly from a comprehensive source: the Current Procedural Terminology, or CPT, Codebook's Integumentary System section. By the end of this conversation, you're going to have a much clearer understanding of the nuanced logic behind documenting and classifying skin-related surgical procedures.
And our mission for you, the learner, is to give you a real shortcut to being well-informed about the often skin-deep complexities of medical coding. We're going to focus on the why and the what it means, instead of just listing facts. Okay, let's unpack this. To truly appreciate the surgical procedures, we really need to understand the canvas itself, the skin. Our sources lay out this foundation, showing us it's far more than just a single layer. We're talking about the protective outer layer, the epidermis, the tougher elastic layer beneath the dermis, and then the deeper fatty subcutaneous tissue. But it's not just those main layers, right?
That's right. It's a whole ecosystem down there. Beyond those primary layers, you've got accessory structures like tiny cutaneous nerves that help us feel, essential blood vessels providing nourishment, and of course our hair shafts and roots, complete with sebaceous glands for oil production and sweat glands for cooling. All these components play a role because different procedures will target very specific parts.
And I imagine recognizing those distinct components is absolutely crucial, because targeting a specific layer or structure directly impacts how a procedure is categorized for coding. So if a doctor suspects something's wrong in one of these layers, how do they even begin to get a diagnosis?
That's an excellent question, and it really highlights the precision of this system. The CPT codebook details several crucial first steps, from taking tiny samples to draining fluid. Let's start with a common one: fine needle aspiration, or FNA, biopsy.
Okay, FNA biopsy. I've heard of it, but what exactly is it from a coding perspective, and how does it differ from, say, a core needle biopsy?
Great distinction. With an FNA, a physician uses a very fine needle to essentially aspirate material. Think of it as gently sucking up cells, which are then examined under a microscope, a process we call cytological evaluation. This is different from a core needle biopsy, which uses a slightly larger needle to remove an actual piece of tissue, a core, for a more detailed histopathologic evaluation, which means looking at the tissue structure.
So it's about what kind of sample they're getting and how they're looking at it. And our sources point out a key aspect with FNA: whether or not imaging is used.
Precisely. FNA biopsies can be done with or without guidance from imaging like ultrasound or x-rays. What's crucial for coding is that if imaging is used for the FNA, the cost and effort of that imaging guidance are usually bundled into the FNA biopsy cord itself.
Ah, bundled, okay.
This prevents separate charges for things that are considered an integral part of the procedure. It's also important to remember that these procedures are typically coded per lesion sampled.
Per lesion.
Right. If you have multiple distinct lesions being biopsied in the same session, there are specific add-on codes to account for each additional one.
That bundling rule really highlights the system's aim for efficiency and clarity in billing. What about draining fluid collections? I imagine that's another common initial step.
It is. For fluid collections like an abscess, hematoma, or cyst in soft tissues of the limbs, abdomen, or neck, there are specific codes for image-guided drainage. Again, the imaging guidance is bundled. And if a doctor needs to place a soft tissue marker, think of it as a tiny clip or pellet to mark a precise spot for future reference, perhaps before surgery. That's also a distinctly coded procedure.
Okay, like a little breadcrumb trail.
Exactly. And the rule here is that regardless of how many little markers are placed at one target location, it's only coded once per target.
That's per target. Makes sense. It's all about precision. What about more general procedures, like simply opening up an abscess?
For simpler incision and drainage procedures, like draining an abscess or removing a subcutaneous foreign body, the CPT codebook has a range of codes tailored to the complexity. A simple abscess drainage would be a straightforward code, while a complex postoperative wound infection requiring drainage would naturally be a higher, more involved code. It's all about matching the code to the level of medical work performed.
What's fascinating here is how clearly the CPT codebook differentiates these initial steps, highlighting the specificity required in medical documentation. It's not just taking a sample.
No, it's about the method, the guidance, and the number of sites. This attention to detail definitely continues as we move to more involved procedures like debridement.
Right, debridement. Now let's talk about that, which is far more nuanced than just cleaning a wound.
Yeah.
Our sources dive deep into how this crucial procedure is coded, and it fundamentally comes down to two things: the depth of tissue removed and the surface area of the wound.
This is where the complexity really shows itself. Imagine a wound that's dirty or has dead tissue. A physician needs to remove that to allow healing. The coding for this changes dramatically based on how deep they have to go and how much area they cover. For instance, if they only debride the very top layers of skin, that's coded differently than if they have to go deep into the muscle or even down to the bone.
So if a patient has multiple wounds, say one on their arm and one on their leg, that are both superficial, do you just add up the areas? Or if one is deep and one is shallow?
Great question, and this is a common point of confusion. The rule is you sum the surface area of wounds that are at the same depth.
That's skip only.
So if you have two superficial wounds, you combine their areas. But you never combine the areas of a superficial wound with a deep wound.
Right.
That's because the deeper debridement is a significantly more complex procedure.
Yeah.
And if multiple wounds are debrided on the same day but are distinct sites, like your example of an arm and a leg, you'd use a special modifier, modifier 59, to indicate they were separate procedures.
That makes perfect sense. You wouldn't want to understate the complexity of a deep wound by mixing it with a simple one. Our sources also mention specific scenarios like extensive infected skin or serious necrotizing infections.
Indeed. For truly widespread issues like extensive infected eczema or skin infections, debridement is often coded by the percentage of the body surface area involved. And for serious necrotizing soft tissue infections where flesh is actually dying, the codes are very specific, not just by location like the external genitalia or abdominal wall, but also by the absolute deepest tissue removed.
Deepest tissue.
Whether it's skin, subcutaneous tissue, muscle, or even fascia. This granularity highlights the escalating risk and resource intensity of these procedures.
And what if prosthetic material or mesh is involved in the infection?
If a debridement involves removing infected prosthetic material or mesh, especially in the abdominal wall, there's a specific add-on code for that. It's a specialized step that reflects an added layer of complexity. Then you have very specific codes for debridement in the context of open fractures, again, emphasizing the depth of what's cleaned out, whether it's skin, muscle, or bone. Finally, for deep tissue debridement, codes 11042 through 11047. When other specific codes don't apply, it's meticulously coded by square centimeters, starting with the first 20 square centimeters and then add-ons for additional area.
Why the granularity? Because the depth and extent of tissue removal significantly impact complexity, risk, and resources. What's fascinating here is how precise the coding needs to be to reflect the true medical work performed. From clearing out the bad, we move to identifying it. Biopsies. Pivotal in diagnosis, but our sources show there's more than one way to take a tissue sample, each with its own coding implications. And there's a really important distinction here about the purpose of the biopsy.
This is a huge aha moment for many. A biopsy code is used only when the physician's clear intent is to obtain tissue solely for diagnostic examination, separate and distinct from other procedures.
So if a surgeon removes a mole and then sends that mole to pathology to make sure it's benign, that's not a separate biopsy code, even though tissue is sent to the lab.
Exactly. That's the crucial point. If tissue is obtained for pathology during an excision, a destruction, or a shave removal, it's considered a routine part of that removal procedure.
Part of the removal itself.
And is not separately reported as a biopsy. The system distinguishes between a procedure performed just to get a diagnostic sample versus a sample that's just a routine check after a removal.
Okay, that's a key distinction. Now, our sources also lay out different ways to physically take a biopsy sample based on depth and technique.
There are generally two depths. Partial thickness biopsies, which just sample a portion of the skin or mucous membrane, not penetrating below the dermis. And then full thickness biopsies, which go deeper into the subcutaneous or submucosal space. Within those, there are three main techniques, each with its own code set.
Tell us about those techniques.
First, there's the tangential biopsy, codes 11112, 11103. Think of it like a very precise shave or scoop with a sharp blade. It removes just the epidermal tissue, maybe a bit of dermis. It's not considered a full excision.
Okay, like a surface sample.
Second, punch biopsy, 11104, 1105, which uses a special punch tool to remove a full thickness cylindrical sample. If a simple stitch is needed to close that small hole, that closure is included in the biopsy code.
Ah, closure included there.
And finally, the incisional biopsy, 11106 and 1107, which uses a sharp blade but not a punch, to take a full thickness sample via a vertical incision or wedge, going deep into the subcutaneous space. Again, simple closure is part of this code.
It sounds like a menu of options, all designed to get exactly the right sample. What if a doctor uses a couple of different techniques on separate lesions during the same visit? How do they handle that in the coding?
It's quite logical. If they perform 2 or 3 different biopsy techniques on separate lesions in the same session, you use the appropriate primary code for the main biopsies, say 11102, 11104, or 11106, and then add-on codes like 11103, 11115, or 11107 for each additional different biopsy performed on another lesion.
Add-ons for the extras.
Exactly. A helpful tip for coders is to usually sequence them from the most complex to the least complex technique used.
This detail about diagnostic intent versus routine tissue submission is a huge aha moment. It illustrates that simply sending tissue to the lab doesn't automatically mean a separate biopsy code is justified. It's about the physician's clear purpose and the independence of the procedure. Once a diagnosis is made, lesions often need to be removed. Our sources provide detailed guidelines based on the nature of the lesion, benign or malignant, its location, and its size. Let's start with something common. Skin tags.
Skin tags. Something many of us have. These can be removed in various ways, scissoring them off, using heat, or even ligature strangulation. The coding for skin tags, 0111 self-100, 11201, is straightforward. It's based simply on the quantity of lesions removed, with one code for up to 15 lesions and an add-on code for each additional 10.
Okay, simple enough. What about shaving off a lesion? My sources say that's different from an excision.
It is. A shave removal, a 11300 or 11313, involves using a sharp blade to remove a lesion by slicing it off horizontally without going through the full thickness of the dermis.
Skimming the surface, basically.
Kind of. Local anesthesia is included, and typically no sutures are needed. This is coded based on the body area, trunk, face, extremities, etc., and the lesion diameter. What's important for the coder is that the doctor clearly indicates they had a therapeutic intent. They were removing it to treat a condition, not just for cosmetic reasons.
So a shave is superficial. What then is an excision?
An excision, the 9, 111400, 11571 malignant, 1117 sextant 46, is a full thickness removal, meaning the lesion is cut out right through the dermis, down into the subcutaneous tissue, including a clear margin of surrounding healthy tissue.
Okay, so for these excisions, whether benign or malignant, how does coding work? It sounds similar for both types.
Very similar principles. Each lesion is coded separately. The code selection is based on the body area and, crucially, the excised diameter.
Excised diameter.
And this isn't just the size of the lesion itself, it's the greatest clinical diameter of the apparent lesion PLOS, the most narrow margins needed to get a complete removal, and this measurement is ideally taken before the incision.
Before cutting.
Simple. One-layer closure of the wound is typically included in the excision code.
What if it's a complicated wound that needs more than just a simple stitch? Like layers?
That's where it gets interesting. If the closure requires more involved techniques, like intermediate repair, layering stitches, or complex repair, those are reported separately using codes from the repair section, 110.031.13160.
So the excision is one code, the fancy closure is another.
Exactly. It's also important to note that you generally can't code an excision separately if you're doing an adjacent tissue transfer, or ATT, 14,000-14302, which is a more complex way to close a wound by shifting nearby skin. The excision is bundled into the ATT code.
Got it. Bundled with ATT. And a special rule for malignant excisions if they don't get all the cancer the first time.
Yes, a very specific rule. If a surgeon removes a malignant lesion, and immediate pathology, like a frozen section, shows the margins aren't clear, meaning some cancer cells might still be there, and they do another excision in the same operative session to get clear margins.
Same day, same surgery.
That you only use one code. That one code reflects the final, widest excised diameter. You don't double bill for the second cut. But if the patient goes home and comes back a week later for a re-excision, that is reported using 11600 or 11646 again, usually with modifier 58 to show it's a related procedure during the post-op period. The distinction between a shave and an excision is very precise, as is the critical detail of measuring the lesion with margins before removal. This raises an important question. How are these defects then repaired if simple closure isn't sufficient?
That's a great segue. When the body's protective layer is compromised, repair can be a complex endeavor. Our sources provide incredibly detailed classifications for wound closures and various grafting techniques. Let's look at wound repair classifications first.
This is a fantastic illustration of medical precision. Imagine a simple cut versus a gaping wound. The CPT system has clear definitions. Simple repair, 12,011 is for superficial wounds, epidermis, dermis, maybe subcutaneous without deep involvement that need just a single layer of closure. Things like local anesthesia are included. They're not separate charges.
So if it's deeper, then it becomes an intermediate or complex repair.
Exactly. Intermediate repair. 1.31 on 12.057 involves layered closure, closing one or more deeper layers like subcutaneous tissue or fascia, in addition to the skin. It also applies to heavily contaminated wounds needing extensive cleaning, even as closed in one layer.
Okay, layers are heavy cleaning.
Then there's complex repair, 1.3.100, 1.31.6, which is the most involved. This typically requires more than just layering. Think about exposure of deep structures like bone or tendon, significant debridement of the wound edges, extensive undermining.
Undermining.
That's carefully separating the skin from underlying tissue to allow closure without tension. It's complex if the undermining distance is equal to or greater than the defect width. Complex repair also applies to critical free margins like the nostril or lip, or if special retention sutures are needed.
Wow, that really breaks down the effort involved.
Right.
What about coding multiple wounds that need repair? Can you combine lengths across different body parts or different types of repair?
No, and this is a key rule. You measure wounds in centimeters. If you have multiple wounds, you only add up the lengths of those that are in the same classification, e.g., all intermediate repairs together. A and D from anatomic sites grouped together, like all wounds on the trunk and arms, can be summed.
So face and leg lengths wouldn't be added together?
Correct. You don't add lengths from different groupings or different classifications. If you have different classifications of repair, say an intermediate and a complex, you typically code the more complicated one as primary and the less complicated one as secondary using modifier 59.
Okay, that's clear. Now, beyond just sewing up a wound, sometimes a surgeon needs to move tissue around. This is where adjacent tissue transfer, or ATT, comes in, 14,14302.
Right. These are sophisticated techniques like Z-plasty, W-plasty, rotation flaps, advancement flaps, where the surgeon meticulously cuts and rearranges healthy skin from right next door to cover a defect. The key point here, as we touched on, is that the excision of the original lesion is considered part of the ATT procedure. You don't code it separately.
So the ATT codes capture the entire work of removing the bad tissue and then rebuilding the area with local skin. What if moving the skin creates a new secondary defect that also needs to be covered?
That's a great example of the layered complexity. If the flap creates a secondary defect that also needs a skin graft to close that hole, then that skin graft is indeed considered an additional separate procedure.
Wow.
And the total area for ATT coding includes both the primary defect, the original hole, and any secondary defects created by moving the flap.
Fascinating. And sometimes you can't just move local tissue. You need a whole new piece of skin or skin substitute.
Yeah.
This brings us to skin replacement surgery and grafts.
Exactly. This broad category covers surgical preparation of the wound bed and then applying various types of grafts. First, there's the surgical preparation itself, a 15,002, 15,005, cleaning and getting the wound surface healthy and ready. This is coded by location and by the size of the area, usually in square centimeters or percentage for infants.
And like debridement, some areas only within the same anatomic groups.
Precisely. You sum the surface area of all wounds prepared if they fall into the same anatomic site grouping.
Okay, then the grafts themselves. I saw something called skin cell suspension autograft, or SCSA, 15011, 15018. That sounds pretty high-tech.
It is. SCSA is a newer cutting-edge technique. It involves harvesting a very thin layer of the patient's own skin. That's the 150-150-12 part. Then preparing it, 150-14, 150-14, by enzymatically processing the cells, filtering them, and then spraying these cells, 150-15, 150-18, onto a much larger wound. What's incredible is its expansion ratio. The sources mention a typical ratio of 1.80.
1 to 80, wow.
Yeah, a small piece of harvested skin can potentially cover an area 80 times larger once processed and sprayed. It's a remarkable way to cover large burns or chronic wounds with a patient's own cells. The prep codes, 15002, 15005, are reported separately, by the way.
That's truly amazing. Beyond SCSA, there are the more traditional autografts where skin is taken from one part of the patient's body and moved to another, 150-15261.
Yes. These include pinch graft, 150-50, split thickness grafts, 45100, 15121, where only part of the skin's thickness is moved, dermal autografts, 15130, 15136, grafts from tissue-cultured skin, 15150, 15157, and full-thickness grafts, 15200, 15261. Each involves a different method of harvesting and application, and if the donor site where the skin was taken from also needs a significant repair, like another graft or a flap, that donor site repair can be coded separately.
And if it's not the patient's own skin, what then?
Then we're talking about skin substitute grafts, 15271, 15278. These involve non-autologous human skin, like homograft or allograft, non-human skin, xenograft, or specialized biologic products that act as a scaffold for the body to heal. The supply of the actual skin substitute material itself is typically reported separately, in addition to the procedure of applying it, and it's also coded by location and the wound's surface area.
Okay, finally within complex repairs, we have flaps, 15570, 15778. These sound like another step up in complexity.
They are. Flaps involve moving a section of skin and to deeper tissues like muscle or fascia from one part of the body to another, but they crucially maintain their own blood supply.
The blood supply is key.
It's crucial for healing, especially in areas with poor blood flow. These codes, like 15570, 15738, typically refer to the recipient area where the flap is attached. If the donor site needs its own complex repair, graft or flap, that's often a separate procedure.
So it's not just moving skin, but moving skin with its own plumbing, basically. Are there different kinds of flaps?
Many. There are direct or tubed pedicle flaps, 15570, 1570, 1576, where the tissue remains partially attached temporarily. Procedures to delay a flap or divide it in stages, 15600, 15638. Then you have very complex ones like muscle, myocutaneous, or fasciocutaneous flaps named by donor site, 15733, 15738. And free flaps, 15756, 15758, where the tissue and its blood vessels are completely detached and reconnected using microsurgery in the new location. These are incredibly intricate procedures.
Microsurgery involved there.
Absolutely. There are also codes for island pedicle flaps, 15740, neurovascular pedicle flaps, 15750, that include a nerve, composite grafts, 15760, skin plus cartilage perhaps, and dermafat fascia grafts, 15770. The system even distinguishes fat grafting harvested by direct excision, 15769, versus fat harvested by liposuction and then injected, 15771, 157774, which are coded very differently based on volume and location.
So much detail.
And finally, things like implanting biologic mesh for reinforcement, 15777, or absorbable mesh for delayed closure, 15778. It's clear that reconstructive surgery is a masterclass in precision, not just surgically, but in documentation. The subtle differences between types of repairs, grafts, and flaps dictate entirely different coding pathways. If we connect this to the bigger picture, it highlights the body's incredible capacity for healing and the equally incredible detail required to facilitate and track that healing.
Beyond general skin surgery, our sources touch on specific areas and unique conditions, demonstrating the true breadth of the integumentary system. Things we might not immediately associate with skin surgery, like nail procedures, LM 17, 19, 10, 65.
That's right. The skin extends to our nails. So there are codes for everything from simple nail trimming and debridement to avulsion, removing a nail plate partially or completely, or even excising the nail and its matrix for permanent removal.
Permanent removal, like for a chronic issue.
Exactly. Perhaps for a chronically ingrown or deformed nail. There are even biopsy codes for the nail unit itself, and codes for repairing the nail bed.
That makes sense. What about something like a pilonidal cyst, 10107, 1107, 1182?
Pilonidal cysts, often located near the tailbone, have specific excision codes depending on their complexity, simple to complicated. Then you have a whole category of introduction procedures, 11100 to 1983.
Introduction procedures. What does that entail? Injecting things.
Pretty much. These cover things like intralesional injections directly into a lesion, like a keloid scar or certain cysts. The coding for that, 11900, 111801, is based on the number of lesions injected, not the number of injections. It also includes procedures like intradermal tattooing, 111910, 111922, which isn't just for art but can be therapeutic, like camouflaging scars or creating areolas after reconstruction, coded by square centimeters. And then, importantly, the insertion, replacement, or removal of tissue expanders, 1960, 1971, think of balloons placed under the skin to stretch it, often before reconstructive surgery, but other than for breast. plus the insertion removal of certain implantable drug delivery devices, Lemonantine 1981 and Lemonantine 83.
That covers a lot. Our sources then jump into a broad category of other procedures, 15780, 15879, which seems to encompass a wide range of cosmetic and reconstructive work.
It does. This section is vast. It covers procedures like dermabrasion, 15780, 15783, which is essentially a controlled mechanical sanding of the skin to improve scars or wrinkles, coded by area, total face, segmental, etc., or chemical peels, 15788, 15793, where chemicals are applied to remove layers of skin, coded by depth, epidermal, dermal, and area, facial, non-facial. You also find blepharoplasty, 15820, 15823, which is eyelid surgery, often to remove excess skin or herniated fat pads. Upper and lower eyelids are coded separately.
And faceless.
Rhytidectomy, 15824, 15829, commonly known as a facelift, which addresses wrinkles and sagging in the forehead, neck, cheeks, chin, includes different techniques like SMAS flap.
So these often have a cosmetic component, but can also be reconstructive, I imagine.
Precisely, and the coding reflects that. Also in the section are codes for excision of excessive skin and subcutaneous tissue, 15830, 15839, like a paniculectomy, which removes a large overhanging fold of skin, often after significant weight loss. These are coded by specific body areas, abdomen, thigh, arm, etc. There's also an add-on code, 15847, for abdominoplasty, often done with paniculectomy. Then there are practical things like the removal of sutures or staples 1 code, 15851 if anesthesia is required, and add-on codes, 15853, 15854 if it's done without anesthesia during an EM visit.
That's a useful distinction.
And checking blood flow in a flap using an IV injection, 15860, and of course liposuction, 15876, 15879, which is suction-assisted fat removal, also coded by body area.
So much detail. What about specific conditions like pressure ulcers, 1592 neuros, 15999?
Pressure ulcers or decubitus ulcers have their own dedicated section because their treatment is very specific, often involving deep excisions in particular bony areas like the coccyx, sacrum, ischium, or trochanter. These procedures can also include ostectomy, bone removal, or require complex closures with flaps or grafts, all specified in the codes.
And burns, 16,000, 16036. How does the system handle those, especially when it's local treatment?
For local treatment of burns, the coding is tied to the percentage of the body surface involved and the depth of the burn, often referencing a standard chart like the Lund-Browder chart shown in the CPT book. Initial treatment for first-degree burns has a code, 16,000. Then dressings or debridement of partial thickness burns are coded by size. Small, medium, or large, 1720336. A critical procedure for deep circumferential burns is escharotomy, 16035, 16036, which is an incision through the tough, burned eschar to relieve pressure and restore circulation. That has its own codes.
And if grafts are needed for burns?
Right. If skin grafts or skin substitutes are applied for burns, you refer back to those specialized graft codes we discussed earlier, 15002, 15278. These burn codes are just for the local non-graft treatment.
Moving to another common procedure category. Destruction of lesions, 17,000, 15999. This sounds like it could be done in a few ways.
It covers ablation destroying benign, premalignant, or malignant tissues by any method that doesn't usually require closure, whether that's electrosurgery, cryosurgery, freezing, laser, or chemicals. For premalignant lesions, like actinic keratosis, there are specific codes, 17,000, 17,003, 17,004, depending on the number of lesions destroyed. First lesion, 214 lesions, or 15 or more lesions.
Grouped by number. Okay.
Same idea for benign lesions, other than skin tags or vascular ones. Codes based on the count, up to 14 versus 15 or more, 7110, 17111, and malignant lesions, 17336, 17382, 17286 are coded by body area and the lesion diameter.
Then there's Mohs micrographic surgery, 17311, 1 Saber 315, which I know is a very specialized technique for skin cancer.
This is a truly remarkable technique, often used for complex or ill-defined skin cancers, especially on the face or areas where tissue preservation is critical. What makes Mohs unique from a coding perspective and clinically is that the same individual must act as both the surgeon and the pathologist.
Ah, the same person does both roles.
Yes. They remove a thin layer of the tumor, map it, process it, and immediately examine it under a microscope right there while the patient waits, checking the entire margin. If cancer cells are found at an edge, they know exactly where to go back and take another thin layer only from that specific spot. This meticulous layer-by-layer approach ensures all the roots of the cancer are removed while preserving as much healthy tissue as possible.
So the codes reflect that multi-stage process and the dual role of the physician.
Exactly. The codes are based on the body area, critical areas like head, neck, hands, feet versus trunk, arms, legs, and distinguish between the first stage, which includes up to 5 tissue blocks examined, 1 seen through 11, 1 seen through 13. Then there are add-on codes for each additional stage, again up to 5 blocks, 1 seen through 12, 1 seen through 14, and another add-on code, 1 seen through 1 seen, for each tissue block examined beyond the first 5 in any given stage.
Very granular. And repairs after Mohs.
If a repair is performed afterward, like a flap or graft, separate repair codes are used. Mohs codes only cover the excision and pathologic exam part.
Okay. Finally, we move to a significant area within the integumentary system section. Breast procedures, 19,000, 19,499. This covers a lot more than just the skin itself.
Indeed. The breast is anatomically part of the integumentary system, and these procedures are a major category. They include things like puncture aspiration of breast cysts, 19,000, 19,001. Interestingly, imaging guidance for this is typically reported separately, unlike FNA elsewhere. Then there are diagnostic procedures like mastotomy, incision into the breast 19020, or injecting dye for a ductogram 19030, and of course breast biopsies 19081, 19026, which are extremely common.
I assume there are different kinds of breast biopsies too,
Well,
like the FNA earlier.
absolutely. There are percutaneous image-guided biopsies in 1981 1986 using stereotactic imaging, ultrasound, or MRI. For these specific codes, the placement of a localization device and imaging of the biopsy specimen are included.
Bundled again.
Right, so you don't code the imaging guidance like 76942 or 77021 separately for these image-guided breast biopsy codes when used for the same lesion. Codes vary by imaging type and whether it's the first or an additional lesion. But if a percutaneous biopsy is done without imaging guidance, there's a specific code for that, 19100. And then there are open incisional biopsies, 19101, where a cut is made to remove tissue.
And if they put a localization device in beforehand, like a wire.
Good point. If a localization device, like a tiny clip or wire to mark a non-palpable lesion found on imaging, was placed before an open excision, like 19125, 19126, the codes for placing that device, 19281, 19105, can generally be reported separately from the excision code. There are also specific codes for cryosurgical ablation of fibroadenomas, 19105, using cold to destroy the benign tumor, which includes ultrasound guidance.
So many specific scenarios.
It reflects the complexity. We also have codes for placing localization devices without doing a biopsy at the same time, 19281, 11288. Codes for preparing the tumor cavity for radiation, 19294, or placing radiotherapy catheters, 19296, 19298, and then, of course, the broader categories of mastectomy procedures, 19300, 19307 for breast removal, and all the various repair and/or reconstruction procedures related to the breast, 19396. What's fascinating here is the sheer level of detail required for documentation. Every layer, every technique, every square centimeter, every lesion counts. This granularity isn't just about billing, it's about providing a universally understood language for patient care, for outcomes research, for quality tracking. It's a way to standardize something incredibly complex.
So what does this all mean for you, the learner? You've just taken a really deep dive into the world of integumentary system surgical coding. We've explored everything from the superficial layers of the skin to complex reconstructive procedures and even specialized breast surgeries. It's a prime example of how even seemingly technical fields are built on layers of precise definitions and, logical rules, ensuring that every medical action is accurately represented.
Indeed. Knowledge is most valuable when understood and applied. This exploration highlights not only the surgical complexities of skin repair, but also the critical thinking involved in accurately documenting these interventions. It underscores the ongoing challenge and really the art of translating human anatomy and complex medical procedures into a standardized system that strives for both accuracy and clarity.
Next time you hear about a simple skin biopsy or complex reconstructive surgery, you'll have a new appreciation for the intricate journey the procedure has taken, not just on the patient, but through the detailed, logical world of medical classification. It really puts a new spin on what it means to be skin deep.
This raises an important question, though. In a world striving for efficiency, how might artificial intelligence or advanced technology continue to refine and maybe simplify this inherently complex language of medical procedures while still capturing every vital detail? Something to mull over until our next deep dive.
Thanks for diving deep with us.